Cardiovascular Population Health and Equity. We are having 4 complementary and very interesting speakers today to discuss, also together with you and here on the panel, how to actually bring research and science into practice and implementation. And we will discuss some of those possibilities and best practices, how this can eventually be done, and also demonstrate how this can be impactful. So we have here on the panel Marcelo Takano. Marcelo is the General Coordinator of Avança Saúde in the municipality of Sao Paulo, with the Secretary of Health of the municipality. And Avança Saúde is a program funded by the Inter-American Development Bank with a focus on restructuring and qualifying health systems with a specific focus on digital health. And he will discuss what this entails. Takano is an orthopedic surgeon by training and a public servant at the Secretary of Health in Sao Paulo. So welcome a lot. Then we have Daniel Cobos, who is the project leader for health systems and policies at the Swiss Tropical and Public Health Institute. Daniel focuses on health system thinking tools and how to apply them to health systems to actually bring also structural change in health systems. He's a family doctor by training and has a background in public health, is the co-lead of the European Union Hub of System Thinking, of the System Thinking Accelerator. He's in the WHO group of verbal autopsy and health statistics. Welcome a lot also to Daniel. Thanks for joining us. Then we have Chi, who is an assistant professor at the New York University in New York at the Department of Public Health and Management. Her studies and research focuses specifically on the role of organizations and management and policies to investigate how equitable access to evidence-based care is provided. She has a background in economics, public policy, management, and public administration. And then we also have Patrícia Ferreira on the panel from the Nova National School of Public Health based in Lisbon. Her focus in research and studies is health policies and administration and the management of health organizations. She is affiliated with the WHO Collaboration Center for Education, Research and Evaluation of Safety and Quality in Health. Patrícia has a background as a family doctor, did her residency in public health, and has large knowledge in information management and also travel medicine. So welcome a lot also to Patrícia. To contextualize a little bit what we are actually talking about, we have actually 3 pillars of topics. One of them being cardiovascular population health and what the evidence is, how to bring cardiovascular population health into implementation in urban centers. From this first pillar, we will discuss what are elements of equity that are relevant to increase access, to improve care, and bring more people into care. And then the third discussion point that we are going to address with our panel is on digital health and how digital health can act as a transformative enabler to increase access, but also to provide more equitable access to health to the population and provide better quality of care. But we will kick off our presentation actually and our discussion with our first panelist, which is Daniel. And I would like to invite Daniel to discuss on the topic of cardiovascular population health. What are best practices from research? How does it get implemented into real life? And what are potential success factors for system change that can be universally applied? So yeah, Daniel, over to you.
Thank you, and I'm really happy to be here in Valencia, in Spain, for once. And so one of the challenges that we see is that there is evidence all over the place, and in cardiovascular disease, there is all sorts of evidence about interventions that work here or there, and the problem is that we tend to use what we call a reductionist approach. So you focus on one intervention, you look at the effectiveness of that intervention, and then once it's effective, you try to export it to somewhere else. And the problem is that it fails completely. And then people say, oh no, but how can this happen? Like it's a problem with the people there. He said, no, the problem is that there are many things going on in health systems. And even if we go outside of health system, there are many things going on in other systems that interact with the health system, the economic system, the social system, and we need to account for those. And just as, I don't know if we can, oh, I am the one in control, sorry. So if we just look at the cascade of care for hypertension or for cardiovascular disease, a very simple one. So we have population at risk living in our communities, living in Valencia here outside, they are at risk of cardiovascular disease, and some of them will have hypertension. Some of them will come to a health facility, to the health center around here, and because they don't feel good, or because they've heard something in the news about hypertension, or someone dying from a myocardial infarction, and they come to the health facility and they are screened. And then they come to the health facility, and some of them will be screened, but not all of them. From those that are screened, some of them will be treated, will be diagnosed, and then will be treated. And from those that will be treated, some of them will continue the treatment and will come to the regular visits, and at the end, their hypertension will be under control. That is the bar there. So if you see, we've been losing patients and people all the way through the cascade of care. And if I ask you, okay, what should we do with this? Should we focus on awareness? And at the beginning of the cascade, should we focus on making people aware of the risk of hypertension, of the risk of cardiovascular disease, that they can die? Should we build more health centers closer to the health to the people so that they can have better access? Should we bring interventions to the workplace, for example, to monitor hypertension there? Or if we go to the next step, should we train doctors and nurses on the risk of hypertension, and that every time a person comes through the door, they should monitor the blood pressure? Should we create protocols? Should we bring drugs to the health facilities? Or towards the end, should we work on people taking their medications? Should we do activities, the doctors and nurses in health facilities? Should we advocate and control patients more often? Should we work on the referral mechanisms? The thing is that we should work on all of it. So if we really want to lift up cardiovascular disease management in this type of situations, we need to work in all these different things. So we need to move from coming back to the first point, we need to move from this reductionist thinking, trying to think that I can only work on developing a protocol, or I can only work on a awareness campaign, to think that we need to work at different levels of the system, and probably outside of the system as well, to be able to be effective. And probably in the course of the conversation and some of the work done in Sao Paulo, part of the success of the interventions and the approach in Sao Paulo has been that they have touched many different points in the system at the same time to lift up what we call the system effectiveness. Is the effectiveness overall. It's not about the drug, it's not about the person, it's about all of it at the same time. So I think with that, I will pass it to Dr. Takano.
Yeah, thank you very much. Thank you very much, Daniel. We also have then a discussion round at the end. So please, if you have any, you can make notes then for Daniel, if you have any questions or you would like to go into details of the concept that he just presented. But now we will go to Marcelo, who will present the priorities of the Municipal Secretary of Sao Paulo. What are the priorities for partnerships, public and private? Where do they currently stand in the digitalization efforts? And what is Avança Saúde? So please, heading over to you.
Thank you very much for the opportunity to be here and share the experience of the city of São Paulo in this process that we call Avança Saúde. Is like a go-ahead health. And I think in the first questions, the objectives of the Advanced Saúde program is much, it's so close with the objective of the possibility of the partnerships. The main goal of the program is expand the offers, not so in the numbers of a unit, but the quality of the health offers, and improve early access and better access for our population, and get better quality of health population. We have 3 pillars in these programs: is the support for the modernization and the buildings of the equipment and health, and improving quality and efficiency, and support the innovation. And the data strategy was connecting all the systems that we have by the digital information, put all inside in one data lake. And of course, we are looking for the standards protocol of interoperability like Agile 7 or FHIR, but it depends the quality of the information by the local ones. And we begin the interoperability with the integration of the health data, and we have to deliver this data not only for the people but from the professionals of healthcare. And this is how we are thinking that the decision making could be possible, and the patient care will gonna better with this analysis. And in the beginning, this is the model that we are thinking about the public health system in Brazil. We add the digital component and the telemedicine and teleassistance for improve better results and quality of not so even track the patient, but improve the protocols and chasing for the better results. To put the patient in the center of the care, I think one of the most important thing that we get in São Paulo. We deliver APP like e-Saúde that target almost 2.5 million people in São Paulo, and we stimulate the person to deliver her data with us, and put the patient in the role of your healthcare. These data are safety and stimulate the primary care monitoring systems. And another function, we get some alerts like the console that the people have, and change, improve the access by telemedicine and all of the steps that the technology may deliver to the patients. This what we are thinking this the best method, not so waiting for the patients entering our doors, but we are looking for the right treatment in based on the protocol. Using data strategy, we tag the patient, and we are follow this patient in all the journey in the healthcare systems, and the monitoring is possible, the opportunity intervention is possible, and the adequate reference of unities is possible. And we are worried about strategy of digital inclusion. Then we set some equipment in our units to deliver technology for the people who didn't have it in their own. And the strategy to take automatic measures like weight or high blood pressure, we are putting in all together in the e-Saúde SP. And promote hybrid access for the people, give their option to make it by themselves in person, or using technology for the assistance.
Yeah, thank you very much, Takano. And I think also then for the audience, you saw a little bit where actually from the cascade of care, you need to make informed decision as a policymaker. Obviously, you need the data. And where does the data actually come from? Then Takano provided a potential solution, how you can reinforce this structure and the databases to take informed decision on government level. Now we have discussed, I think, a lot around the healthcare system, and I think also in the spirit of the conference, we would like to go beyond the healthcare system, as urban health is a interdisciplinary endeavor, and this is now also where G comes into play, which will give us an overview of what the situation is in New York and what insights potentially can help to use data to inform activities or implementations around health equity. So please, G.
Hi, glad to be in front of a very friendly audience. So I'm presenting the priorities of New York City around health equity and how data can be used to address these priorities. And for those of you who have been to New York, you know that New York is known for many things, right? We're known for it. We're known as the city of lights. We're known for Broadway, the glamour, the wealth. But in fact, New York is a very, very diverse place. There's over oops, okay. How do I? Oh, there you go, oops. All right, so New York is also a city of neighborhoods. So you could walk a few blocks and be in a completely different neighborhood with different types of food, different languages spoken. There's over 700 languages spoken. So New York is a city, it's a world within a city. Now, the thing about these neighborhoods is it carries with it a history, and that's what makes it very special. But these neighborhoods are also divided along many lines. They're divided by the level of wealth that's distributed, and that also corresponds with the resources that people have. And so if you look at the map here, you will be able to see that this is the distribution of wealth in the city. And as you can see, very similar to any other place in the world, places with a cluster of wealth and resources also have better health outcomes. So specifically to cardiovascular disease, the lowest income neighborhoods have twice as high of a risk of premature deaths related to CVD than the highest wealth neighborhoods. And so when you're thinking about the priorities of the city, it's twofold. Okay. It's twofold. There is a goal citywide to improve the health of populations overall, but there's also a very important secondary goal to improve health equity. So while we are uplifting the whole population, we also want to focus very specifically on those neighborhoods where you have the highest gap in health outcomes. And so Take Care New York is a blueprint of the city to improve both health of the entire population, but also health equity. And it's to improve health, everyone's health, and make greater strides with groups specifically that have the worst health outcomes. And so how do you do that? You do that by recognizing, as Johannes said, not just the things within the healthcare systems, but outside of it, right? So people's access to employment, education, physical activity, poverty, violence, structural racism, all of this matters. And when we spoke to the stakeholders across the city, they recognize that there's three things that must be done to address these priorities. First, you have to be able to measure it correctly, accurately. Second, once you have those measures, how do you actually bring it together to deepen the understanding around these issues? And then finally, once you have a deeper understanding, you could develop interventions to address these issues. And so where we come in, we're not doing the primary data collection, but we recognize that there's already a lot of data available. There's a wealth of data available, both publicly and also privately. And so what we are doing in our project with the Novartis Foundation is we're pulling together data, social determinants data at the neighborhood level. Most of these are publicly available. So things like the crime, the level of crime, we could pull that from the New York Police Department. We have the measures of the banked or unbanked, that's available. All these social determinants data at the neighborhood level, and we are linking it with limited data that's also from the city. So for example, the proportion of premature deaths associated with cardiovascular disease, we obtained that from the Department of Health. And we are also linking it with private patient level clinical data from a large health system.
Great, thank you very much. Also to show kind of the overview and the depth of what drives inequity, and interesting to see also how this is distributed in the different neighborhoods. Perhaps we can go a little bit into detail also then in the discussion. But now handing over to Patrícia, who is going to talk about how Lisbon could act as an example for the European Union in addressing social determinants of health on the municipal level.
Thank you. Thank you so much. It's a pleasure to be here talking a little bit about the example of Lisbon. And Lisbon is a city that is, of course, an example for what is happening in many cities around the world. So just to give you a first picture of what's happening in Lisbon. So over the past 4 decades, we have seen some changes in our population, either in its growth, in its age structure, in the conjugal patterns, in the ethnic diversity. So we have seen a rapid decline in the rapid aging in our population. So just to see the bigger picture, in 1981, we had 807,000 people living in Lisbon. And right now in 2021, according to our most recent census, we have just 546,000 people. That's around 5% of the total population in Portugal. Of course, we are also seeing a big aging in our city. In 2017, we were considered the oldest capital in Europe. Most recent data shows that we are still one of the oldest capitals and one of the oldest countries in the European Union. And of course, these changes affect the size, the composition, and the structure of our own households. And this, of course, modifies the health paradigm that we have in Portugal and in the city of Lisbon. So these changes need to be necessarily put together with changes in policies, especially those that regard health, inequities, and social determinants of health. So consequent to this aging population, we are facing a shift that translates into a demographic and an epidemiologic transition. So in simple terms, what we are facing is a shift from a population that dies to a population that right now gets sick. So a shift from mortality to morbidity. We have a shift from getting mostly infectious disease to having right now more non-communicable diseases. And all of this, of course, translates into a disease burden that shifts from younger populations to the older ones. So this means that health policies should be targeting different outcomes and, of course, different population groups. And as always, and G pointed an example in New York, because this happens everywhere. This shows the relationship between disease and low income. So when we talk about just cardiovascular health and disease, and we see that in Portugal and in Lisbon, women have higher mortality and worse prognosis after acute cardiovascular events than men. We have a clear association between morbidity and mortality by cardiovascular disease in lower social economical groups and other social determinants that affect these groups. We have racial and ethnic ethnic minorities and groups that are affected and burdened with poor health outcomes, severe health outcomes, worse in Lisbon and in any other city of the world. So in accordance to the global findings, we found an association between morbidity and mortality of cardiovascular disease and a lower socioeconomic status and other social determinants of health in the Portuguese population. So what this really means is that it's impossible to really tackle these health problems such as cardiovascular disease without taking into account the social determinants of health. So this highlights the importance of a more comprehensive and interdisciplinary and intersectional sustainable health policies that really takes into consideration not only the individual, but the cultural, the socioeconomic characteristics throughout the entire life circle of the individual and their population to really promote health and to prevent disease. So this is our first insight from our project in Lisbon. Thank you.
Great. Yeah, thank you very much for the presentations. Also to opening the floor for our discussion now. What connects actually this group here are those three elements that I mentioned in the beginning: cardiovascular population health, health equity, and digital health, which are executed and implemented and brought to reality with the support of the Novartis Foundation with two programs. The one program called Cardio, which some of you already heard before, the evidence that was presented in one of the oral presentations. And the other program is called AI for Healthy Cities, which looks at how equity findings in social determinants of health can be made available for decision-making of public entities and brought into concrete implementation on a municipal level. And to make it a little bit concrete, we can also then discuss with our panel, and we are also happy then to receive your questions and challenges and any doubts that you have. But I would actually like to know first from Daniel, because you showed the cascade of care in the beginning, how you actually can imagine to bring this cascade of care into a health system decision-making process, and what kind of tools do you have experiences with how this can be done, and what you can share also with the audience here.
Okay, thank you. And if you can, the presentation. Yeah, so the thing is, when we come to talk to policymakers and we describe what I described to you, like, look, there are many different factors that influence decision making. They say, yeah, but you know, this is really complex, and really I don't care, and I'm gonna be here for years. So what can I do in the next 4 years that can improve cardiovascular health in my region? So we, in a way, we need to, first of all, not only making systems aware of the complexity around, in this case, cardiovascular disease, but also bring tools that can help people make decisions accounting for that complexity. So in a sense, there is a pathway towards understanding the complexity in the system, but then also bringing the complexity to a place where it can be useful for decision-making processes. And for that, we use a number of tools that we brought them from system science and system thinking science. And one of them is system dynamic modeling. That is the one that hopefully we will be able to use in Sao Paulo. And the idea of, I don't know if it's there. Oh, yes. So the idea of the tool is, the idea is to look at the system dynamics. So in the system, we have all the different elements that interact. So we have the final outcome, in our case, hypertension under control. And there are many actors influencing that, from food companies to the health system, to the environment, to the individual. Like all of those dots, there are actors interacting and factors interacting to each other. And then we have the dynamics, the dynamics, the evolution. Yeah, the evolution of, in this case, like one indicator. So we try to bring those two things together into and what we call a simulator. And the idea of the simulator is you build with the actors in the system. You understand with them the complexity of the system. You model that, and you create a model that explains how the system operates in in today, why we have these levels of hypertension control, and what are the factors that influence that. And once you have that model, then you can have like a simulator, like an airplane. So there are many times in policymaking there is a lot of what if scenarios. Like, what if we stop this intervention? What if we bring this intervention? What if we do this and that? What if I have $100,000 and this is what I have to invest? What is the best mix of interventions that I should do? So with the simulator, you can test all of those things without actually having to implement them in real life. So it's a way to facilitate a discussion that is built over the same foundation for all the different stakeholders. Because one thing that we see also is that every actor in the system has their own view of the system. So the doctors, they see their small part of the system, the nurses, they see their part, the managers, they see their part, the data people, they see their part. So everyone has their own vision on how the system operates, but no one has like a shared vision. And what the simulator can bring, this discussion, this participatory discussion, bring the same foundation for the discussion, which is very interesting. And in the case of Sao Paulo, there are elements that are really attractive for this type of approaches. First of all, you have lots of data and good data, integrated data in one platform that Takano was mentioning. And also there is the approach towards health for the system in Sao Paulo and in Brazil, I would say, is very much tackling many different factors, not only healthcare, but tackling health and individual and social factors at the same time. So it's kind of the perfect scenario for testing this type of tools, and we hope that we can implement it with them.
Yeah, thank you very much for the answer. Some of you in the audience probably also witnessed yesterday the plenary discussion, where actually also other methodologies were presented for healthcare system simulation. What Daniel now presented with the system dynamics modeling has the advantage that eventually it is a white box, that the elements of the simulator is created together with the authorities. So it's not an algorithm where a technical person only knows what is going in and what is going out, but it has a combination of quantitative and qualitative assumptions that can be taken then for improved decision making. But this is also obviously up for discussion. If you have any subjection or criticism, welcome to also discuss here, and happy to hear your thoughts. In that perspective, I think for data-based decision-making, I would like also to Takano to share a little bit what his learnings are. If you look at the patient population, at the healthcare professionals and the healthcare system, how decision-making is actually advanced in the healthcare system, and what kind of opportunities and challenges you encounter when working with the data and making it fit for purpose.
Yes, we really think that the data strategy is the best way to get this objective. When you put all the informations that comes from the original system in the one single data, we can identify the population with more effective and most completely form that we are sure that nobody is get out of the analysis. We can improve the strategy to perform the cardiovascular risk calculations with informatized tools, and bring the patient for the beginning of this process. We are used to be thinking that the only mission that we have is open doors in our units. Then we are really sure that we have to looking for these patients. Another strategy is get the job from our professionals easier. And when you propose the data or digitalized platforms, we can capture the data in the more effective forms and do this automatically. When we changing some keys of the protocols, like how many consoles that the populations of target got in the systems, and follow the points that we are made the conclusion if the hypertension are or not controlled. And when you do all of these things in the integrated forms, by sure we will have a better results in the end of the day.
Yeah, thank you very much, Takano. I can also then probably, if you imagine that data comes into the healthcare system and it actually makes processes more clear and obviously also more accountable, there are many hurdles to overcome with healthcare professionals or in the health system to actually use data as a basis for a decision-making process. But it is also, I think, quite a strong change management exercise. Now moving again a little bit into the equity area, you presented also that there are many data already available. I would like to hear from you a little bit on the one side, what kind of opportunities and challenges do you see to bring those databases together? And then on the other side, I think you also said in your short presentation that this is actually also sort of a known historical structural problem. So I would like to know from you what you actually think is the window of opportunity that we have currently to do something about this.
So thank you. So there, as I mentioned, there are lots and lots of data points, right? There's a wealth of data that resides both within the healthcare system, patient data that's protected. There are publicly available social determinants data that's available, and also limited data sets that's available that we have to ask for. When we first started off on this project, we wanted to see, number one, what kind of data is out there, and also how is it being used? What we're doing is not necessarily new. We're trying to create a map of social risk, and that's already been done before. I think the problem is what variables actually go into that model meaningfully. How do they cluster together? And then how do we then map it out in a way that could shape decisions? And so this is a lot of moving parts. We are working with partners that the decision makers that we hope will be using that data to identify what do you want to measure. So for example, when we talked to the health authorities, they pointed to this idea about historic divestments in communities. And so how do we create a measure that brings in some of that value, the history of structural inequities, along with the current data points that we have? And so when we're looking at our model, first, we're bringing in the whole kitchen sink, right? And then we are working with partners at Microsoft AI to then, okay, how do we then see how these different variables clustered together so we could get a more parsimonious set of data that can be clustered in different domains that then shape decisions. And so I think if I were to think about the biggest challenge, number one is getting access to the data. We're trying to address that right now. And then second, what is the right model? I mean, the systems dynamics model is one of the ones that we're assuming would work, but there might be other simpler models as well. And so we're working with analysts at Microsoft AI to see, which is the best model that we could use that could then apply, over time, that we could run this model again and again every year to see how these different relationships change over time. So.
Yeah, thanks a lot for giving us this overview. I think also, Patrícia, you are facing similar issues also around the data strategy with data owner processor. I think also what probably the audience has a lot of experience in, at least for research, how data is shared, analyzed in a consortium way, for example. But I would like to know from Patrícia if you presented the situation in Lisbon, which I think is pretty representative also for the European level in terms of change of aging population, what the difficulties are for the city of Lisbon. So I would like to know what, from your perspective, what do you see in bringing those scientific insights into potential implementation? What would you assume are factors that are factors of success and would need to happen on municipal level?
So it's really interesting to be here and share experience, because we are still in a phase of our project that's still a bit behind from the New York project. So we learn with their experience. But we are right now in a step where we are trying to figure out how to use the data that we have. And we have in Portugal, we are a leading example in the Europe of digitalization of health, because we are lucky enough to have at a national level pretty much everything in electronic and digitalized way. So we have a patient electronic health record, we have vaccination registries, medication test results, so death certificates, everything you can pretty much think about. We have that at a national level, and it's owned by the public system, but that doesn't necessarily mean that we have access easily to that kind of data. So what we have in Portugal is that we have so much data that's not being used to anything pretty much. I mean, to research in a small scale, to some policies in a small scale, but not really getting what the evidence is out there and trying to make insights and trying to make policies. So that's the phase we are in, and trying to prove the importance of this project and how it is important to have this data, because it's not just health data, it's social determinants health data. It's about the way people are living, and people are living in Lisbon. So this is important to create policies and to make a change, because I think this happens in Lisbon. I'm pretty sure it happens everywhere in the world, to make a change from a more curative medicine, that's what we have right now, to a more thinking about health in policies to a more holistic and integrated way of promoting health, protecting health and preventing disease. So I think we have the infrastructure, the data infrastructure, so now we just have to leverage that information into actions and into wisdom.
Yeah, thank you very much. I think this is also kind of a cross-cutting element with the speakers here, that if you have the availability of data, this needs to be communicated in a strong manner and also made extremely relevant for the target audience. I would like to open also to our audience here. Some people have experience with what we have discussed here, and we are happy to receive any comments, questions, critique on the approach, on ideas that you have found in your own research or implementation science. So happy if there are any questions from the audience, open for discussion with the panel. Please, yeah, two. We have still one in the back. Who wants to start? Yeah.
I can start like general, and probably you go to the specifics. So I must say that hospital data is not, I wouldn't say that it's very available for governments to work with. Hospitals, they usually have, my experience, not in Sao Paulo, but my experience in different countries, hospitals, they usually have their own information systems, like privately developed, and they have their data, but this is difficult for them to share that data at the national level. And I do think that there, in the case of Sao Paulo, there is lots of data from primary healthcare that is very, very useful, and it's actually being used very much in the study. But I will let, yeah, Takano.
I think the problem with the hospital data that is focused on the disease and the treatment, or the logical by the payment for the government. In Brazil, we have a strong strategy to fertilize the digital data from primary care. We have a program that calls Prevention Brazil, that stimulate the government to register each patient that they have in the territory. And nowadays we are improve the quality indicators for improve the payment for the government. And digitalize is a very nice strategy to get these numbers high. I think the digital, not the primary care data and hospital data, but the system that we call regulation for the access from the systems. That is the data that we think is more powerful because they measure the needs of the population.
Great, thanks a lot. So this is a little bit a question, follow the money, and also the incentive then probably from the federal government that actually came to the municipalities in Brazil was to measure those indicators so that solutions are found on a lower level of care. And this is a possibility also, I think federal government can institutionalize policy how to strengthen data quality in primary care. We had a question in the back. Please.
Thank you. Thank you. Faston Goma from Zambia. Just trying to get some more depth into appreciating exactly what the determinants are that we are discussing. I think there's a lot said, you know, that people in the lower socioeconomic bracket tend to be more disadvantaged, but what exactly is it that puts them at that disadvantage? Is it health financing? Is it health-seeking behavior? Because we know poor people behave poorly. And I mean, probably I should leave it there. What exactly is it that we are seeing that says that points to poor outcomes in poorer communities?
Yeah, perhaps I pass it to Gia and Patrícia.
So that's the $1 million question, right? I think it's really hard to parse out. I think we do recognize that wealth and health outcome and social economic status and social determinants do cluster together, and that does link to poor health outcomes. But in terms of the pathways through which it gets there, that's very, very complicated. And I don't have a clear answer. There's a lot of papers that's been written on this topic. They do point towards specific relationships between, for example, education. There's a very strong relationship between education and cardiovascular health outcomes. Same thing about healthcare access. So if you're living in a place where you have fewer touch points where you could get preventative care, you're likely to have poorer outcomes. But in terms of how they work together, that's a question that we don't have the answer to, unfortunately. Perhaps these projects will help us get closer. What I will say, though, is I think that there is a recognition that social determinants it's not just one or two things, right? There's different domains. At least for the study that we're adopting, there are different domains that we're looking at. We're looking at education access and quality. We're also looking at healthcare access and quality, but we're also looking at things like the social cohesion, right? So there's a level of trust in a community. Do I trust my neighbors enough? There's actually measures for that. And so that's one of the measures that is going into our model, the level of social cohesion, community context, the built environment, right? So how close am I to the nearest bus stop or to the nearest metro station? And so they cluster around these different 5 domains. I don't think that for our project, our purpose is to know directly the link, but I think it's sort of recognizing how they are broadly associated with cardiovascular outcomes. But I don't think we can answer, it's just one or two things, right, that leads to these poor outcomes.
So I'm not really going to add anything theoretically because I think G's pointed out pretty much everything. I'm just going to give the example of Lisbon because in this project we are working with the City Council of Lisbon. So they don't really they don't really want theoretical answers. They want interventions on how they can help the community. So that's hard to give them, but that's the process we are trying to solve, or to at least in a small scale to give them some answers. And we are looking at things like mobility and access to healthcare services, and how we can help the population in Lisbon, because as I pointed out, we have an elderly population that's living isolated in the capital city of Lisbon, because younger generations cannot really afford a house right now in Lisbon, so they move through to the other neighborhoods around Lisbon, but not really in the city center. So we don't have the sense of community, we don't have the sense of neighborhoods, and we have people from Lisbon that have lived their entire life in that home, in that place, feeling alone and feeling isolated in their own city and the place that they lived for so many years. So that's the issue that we are trying to give some ideas to the city council, how they can intervene in that, and of course how we can improve the outcomes of cardiovascular health and disease. That's the main goal here. But yeah, there's no solution fits all. There's not an answer that's going to give us a Nobel or anything like that. But we are working with the community and with the policymakers.
Yeah, just a point on, well, 2 points on this. One is that probably, so this is, as I see it, is very much influenced by the context. So what the factors that are relevant for New York are different to Lisbon and different from Zambia, and is different within Zambia from Lusaka to other parts of the country. So it's very context specific. There are general kind of trends and things that seems to influence, but then probably you need to need to contextualize. Okay, in my area, in my setting, the region that I'm trying to intervene, like what is going on. And then following up on what they were saying, for me, the interesting part is how these different factors intersect and how they cluster each other. And this is difficult to do it at the individual level. Like for each and every person of that city, it's difficult to do it. But similar to what she was describing, like if you go one level up to the city or to areas in the city, these factors intersect like much easier, like socioeconomic status, with access to healthy food, with access to mobility, to safe transport, blah, blah. Like all these things are clustered in areas of the city. And I don't know, probably similar to what you were planning to do, but there is this idea of, there was this idea in Mexico of creating a map with obesogenic environments in one of the city. I think it was Guadalajara, I think. And this is because some of these factors are clustered more closely in some areas of the city or in a region. So I think that's one way to approach it, also to make it useful for policy making, because you cannot go to the individual level from a policy perspective. You go to the population level. So in that sense, if you bring, look, socioeconomic status is related to cardiovascular disease, they say, yeah, okay, good. But if you say, look, in these areas of the city, there is a higher risk of cardiovascular disease for this and this and these factors that influence each other in this way, for a policymaker, it's much easier to intervene, to do things that affect populations.
Yeah, so it's a little bit then also the image that you brought with the different perspectives of the healthcare system, where we would say that you can describe it as an elephant and people look at the different aspects of an elephant. So probably you can transfer this image from the healthcare system also to urban health setup with equity. So that it's actually a little bit more holistic perspective with those factors interacting. I give it again to the audience. We are also happy to take any critical points on the methodology that we prepared, that we presented here, or any learnings that you have from your own work, bringing science to implementation and working with national governments.
Yeah, just on how you bring evidence to policy. And for a painful part of my life, I was doing systematic reviews and I was working on this knowledge translation type of work. And for me, and then after that, we've been part of this project and also other projects is how you influence decision making at the end of the day. And what I realized personally is that we know very little about the budgeting and planning processes of governments and where information is relevant, when, to whom. So many times we produce evidence, really nice reports and things that they cannot be anchored at any point in the decision-making process in government, or you are targeting someone that maybe this is the person that is receiving, but cannot make any decision at all whatsoever on the problem. So also for me, it's not only about data or how you put the data together that is important, is how you target this data to the right place at the right time to the right person so that the decisions are made. Because for me, that's a part of the puzzle that is still missing, like how do we influence decision-making process, and also like how you, like it's a matter of how you influence people, influence policymakers with data, with evidence, so that the decisions are better in principle. And that's not really clear. How do you do that? So this is a challenge that we probably need to navigate.
Yeah, thank you very much. I think this connects also a little bit to the thought that we had earlier, that actually healthcare systems would move from a model that is also disease-based to a model that has a forward-looking perspective that is more predictive, and actually how you can translate this vision and idea into something that brings relevance for the decision maker. Yeah, but I think to close this panel, I would like to know from all of you what would be one of the core recommendations or core enabling factors that you would like to see in your environments, how to actually bring this idea to build a more predictive and proactive healthcare system or urban environment to establish more equitable health systems. So what would be your core recommendation or ask to make this a success?
For me, is understanding that we live in what we call complex adaptive systems, that are systems that are dynamic, are moving all the time. They are influenced by other subsystems. And if we want to improve cardiovascular disease, we need to bring the different views that exist in the system and the different understandings to a common view. And that's difficult to do. And we have some approaches, but not all of them are successful. But this idea of bringing the different lens and the different views to the table of where the decisions are made, I think is key.
Anyone else with a core recommendation?
So I think I love how Johannes keeps asking, what's a criticism that you have to the audience, right? I was smiling every time. If I were to critique the project that I'm leading, it's that a lot of the data that we're collecting is at the community level, right? And I agree with you. I think that at the individual level, it's harder to understand how the variables clusters. That's why we're going at the community level. We're getting zip code level data, but that leaves room for ecological fallacy, right? So in one zip code, there might be a person who has an income of $200,000 that lives one block away from someone with $20,000, right? And we don't have that level of granularity at the household level, at least for the data that we have access to. That's why we're linking it to patient level data, and we're trying to validate, does this actually translate when when we're actually going down to the patient level? The patterns that we're seeing at the zip code or community level, does it then translate so that we don't fall prey to ecological fallacy? The problem though is once we get down to the patient data, the data that we're collecting about, the data that is being collected about social determinants, it's very sporadic. It changes over time. It depends on when you're asking the patient, right? Depends on who's asking the patient, right? And it depends on whether it's being asked at all. And so there's a big gaping hole. You know, when we're asking patients, for example, quality of care, the patient's assessment about their own quality of care actually maps very closely with these outcomes of clinical care. I suspect the same to be the case for social determinants. Now we could get this, public community level data that might be objective, but it might not map with the patient's actual experience of their social needs. But the problem is that patient data is not being collected. And then number two, it's not being collected systematically in the same way. Sometimes it's written into clinical notes. So if I had one hope, right, or one solution, it would be for a systematic set of social determinants measures to be collected and owned by a patient. So you're not constantly asking them these questions about, are you housing insecure? Are you food insecure? These might be uncomfortable questions to constantly answer. And so if the patient could just have one set of data that they own that can be shared and logged into the system, whatever system that might be, and that could be drawn by researchers, I think that would be my hope.
Thank you very much. Also taking up the point then for the criticism, because then we can see how we can potentially address this. Any statement from Patrícia Takano on the core recommendation on how to build more resilient healthcare systems?
As I agree with G that we have to propose a more effective strategy to follow the social determined by individual. I think we are in this right way in São Paulo and get this data in the prospective form and with more interaction with the government and the decision makers and the individual patients. And we have to change the mindset of our decision makers. Just not think only about how many equipments we have to open or how many hospitals we have to rise. We have to put the idea that we have to deliver the patient the correct needs of the patient, just to offer the equity. The equity it's offering for the people who most need it, and that is our principal core message that we would like to give it to home.
Thank you very much.
Yeah, just to add a thought, I do believe that it's important to engage patients and communities and citizens into this process of data and health data, because this data does not belong to institutions that host them. It belongs to the persons they are referring to. And I think that most of the times people are not really aware of what could be used and the power of that data that can be used to transform cities and transform communities. And I think that we need to bring them to the conversation, because I mean, people easily give the rights to their data from other industries for other purposes. So why not bring them to the conversation about health data and perhaps using the power of AI to improve the insights that we can gather from this data. So I think that's important to bring them to the conversation.
Very much for your closing remarks, and yeah, we landed also on the spot in terms of timing. I would like to thank you all for attending, and have a great conference, and we see each other then around on the corridors. Please, yeah, thank you.